Thank you, Frank. Can people hear me okay? Is this coming through?
Yes, it's coming through.
Great. It really is a pleasure to talk to you, and I regret that I'm not there in person, and I want to emphasize that it's not for lack of trying. We spent 4 hours at the airport last night. Our flight came in, it was first delayed and then canceled, so I regret that I'm still here. I want to begin by just defining for you what obesity is and the criteria we use. We use the body mass index to define cut points for obesity. The body mass index is weight in kilograms over height in meters squared. And to give you a sense of what that means, that a BMI of 25 is the lower bound for six-foot-tall man who has a BMI of 25 is 184 pounds. For a woman, 5'4", it's 145 pounds. At a BMI of 30, which is the cut point for obesity, men have a weight of 221 pounds and women a weight of 174 pounds. There's a lot of misclassification, particularly for men, between a BMI of 25 and 30. But for both men and women, a BMI greater than 30 is invariably associated with increased body fat, unless you play linebacker for the New England Patriots. In kids, the criteria are different because children are growing. So the cut point for overweight is the 85th percentile of BMI, and for obesity, it's the 95th percentile BMI. And it's important to emphasize that those standards are based on national surveys that were and data that were collected prior to the rapid increase in obesity. So these are a historical standard, and it makes it possible for 17% of children to be greater than the 95th percentile. Now, if I could turn to the first slide, this shows the obesity trends in 2 to 19-year-old U.S. children. These are nationally representative surveys with the exception of the 63 to 65 survey. And you can see that there has been a substantial increase in the prevalence of obesity beginning in 1976, 1980, or I should say between 1980 and 1988, 94. And as I said before, the standards are based on data collected before 1976, 1980. That was the date of the first NHANES survey, the second NHANES survey. NHANES is the National Health and Nutrition Examination Survey, and as I think many of you know, this is a representative survey of the children and adolescents and adults in the United States. These increases are not limited to U.S. children. As the next slide shows, excess body weight has increased across the world, and these are representative data mostly from the developed world, but we're seeing increases in the prevalence of obesity around the world, even in underdeveloped countries, although the prevalence is much lower. The data here are not as clear as to where the inflection point is, largely because I don't think other countries have the same quality of the data that we have. Nonetheless, you can see that the prevalence of obesity in children and adolescents around the world in these developed countries has increased rapidly. Now, going back to the U.S., and the next slide shows the changes in the prevalence of obesity among U.S. men. And over this period between 1976 and 1980, and 2003, 2004, in this particular study, the prevalence of obesity doubled, and it was a pretty uniform increase across all three ethnic groups: Caucasians, African Americans, and Mexican Americans. The next slide shows the same data for women. Again, although there are already differences in the prevalence of obesity by 1976, 1980, the increases that occurred between that NHANES 2 and the beginning of the current NHANES, which were collected in 2-year intervals, again, the prevalence has roughly doubled pretty uniformly across non-Hispanic whites or Caucasians, non-Hispanic blacks, African Americans, and Mexican Americans. It's also important to understand one of the very prevalent misconceptions about the, obesity and its relationship with poverty.
The next slide shows the prevalence of obesity by socioeconomic class among men. There is no significant relationship with poverty and obesity in non-Hispanic whites, non-Hispanic blacks, and Mexican Americans. And interestingly enough, the only socioeconomic relationship is among upper income blacks and Mexican Americans, in which there's a higher prevalence of obesity among upper SES groups. In women, the story is a little bit different. If you look to the right of this slide, you can see that among all women, there is a relationship between obesity and poverty. However, that relationship is limited to the relationship between poverty and obesity in non-Hispanic whites, that is, Caucasians. There is no socioeconomic gradient, significant socioeconomic gradient among African Americans or Mexican Americans. It's pretty flat across these groups, as you can see, and although they're looked to as though they're subtle differences, those differences are not significant. These rapid increases are not explained by genetics. It's true that there are genes related to obesity. There are about 100 genes that have now been linked to obesity. But those genes have always been present in the population. So these increases these increases have occurred despite this, the genetics that have always been present. And I think the way to think about this, and in the discussion that follows, the way to think about the obesogens and many of the things that are going to be discussed, the way to think about these is that these are factors which influence susceptibility. That the factors which, with the mechanism by which these operate is through their impact on energy balance. Now, as the next slide shows, these differences that accounted for obesity over time are relatively small. Now, this slide shows the daily energy deficits necessary to achieve the Healthy People 2010 goal of a prevalence of 5% by 2020. And the way to look at these data is that this flips the weight gain. So these deficits are also the caloric increments that accounted for obesity over the last 10 to 15 years. And you can see that these deficits in children particularly are quite small. And it's important to recognize that in the 2 to 5-year-olds, that's only about 30 calories a day, a daily caloric deficit necessary to get the mean BMI back to where it was by 2020. And we'll see in a few minutes just how relevant that is to the current trends in prevalence. But even among 6 to 11-year-olds or even among adults, this caloric deficit is relatively small and achievable with modest changes in dietary intake. Bigger changes, obviously, in physical activity because it's much more effective and efficient to lose weight by changing dietary intake than it is to increase physical activity. Now, the complexity of obesity is emphasized in the next slide. This comes from the Foresight Office, the science office in the UK, and an expert committee got together now almost a decade ago and began to map the various pathways related to obesity. These orange lines in the center are the critical interaction of energy intake and energy expenditure. And it's that imbalance which accounts for obesity. But all of these other pathways and the relative impact of these pathways is exercised through their effect on energy balance. And these have been shown in more detail in this slide, showing that which largely groups these variables in terms of food production, consumption, societal influences, psychology, physical activity, which is the counterpart of the energy balance equation, and one which, in my view and that of a lot of other people, has largely been neglected with the focus on food production and food consumption. And then biology. And I think that most of today, and we'll focus on the biological impact. These are mechanisms that affect the pathways which regulate energy expenditure. The microbiome falls into this, obesogens fall into this, endocrine disruptors fall into this. And these are obviously going to be mediated through perhaps some of these other mechanisms that govern food consumption and physical activity. Now, again, as I said before, I think the way to think about these other multiple factors is that these operate through energy balance. But these other factors affect, in my view, the way to think about them is that they affect susceptibility. They don't cause obesity in the traditional sense of biologic agents. And for the rest of my presentation, I'm going to focus on, excuse me, on the macro environment and the behavioral influences, and Jerry is going to focus more intensively on some of the biological influences. The next slide shows what an average family of 4 consumed in the 1950s. We really were a milk and meat and potatoes society. Milk, meat, and potatoes. You can see the milk in the foreground, the potatoes right behind them, meat behind that. The only processed foods in the 1950s were up in the upper left-hand corner of this slide, and you can see there cornflakes and some Wheaties. Who knew that Wheaties were this old? But the rest of the diet was largely raw or unprocessed food. The next slide shows what an average family of 4 consumed in the course of a week in the United States. And you can see here that pizza plays a prominent role. All of the foods here, most of the foods here are processed. You can see some fruits and vegetables in the background. You can see sodas in the background, relatively small amounts of milk. And these shifts in food practices are enormous. And are a consequence of the factors that I've listed here on this slide. Healthful foods cost more, and the converse is that junk foods, processed foods, cost less. Portion size has increased substantially, and the processed foods, as this family indicates, are substantial. The variety of foods have increased, the availability of foods has increased, and the foods available in school vending machines and a la carte have, up until this administration, have been quite diverse and increased. All of these factors promote increased food intake. We know that the more variety an individual is exposed to, the more likely they are to overconsume foods. The greater the portion size, the more likely we're to overconsume. The lack of volume because of reduced fruit and vegetable intake displaced means that higher calorie foods are likely to account for a greater part of the diet. So we don't have to go very far to see the multiple changes in food intake that could contribute to the epidemic of obesity. There have been comparable changes in physical activity, less quantifiable, but nonetheless important. We've eliminated physical education and recess from our schools. Screen time has increased across the population, particularly in children. Appliances have displaced what used to be household activities, like washing the dishes, hanging up the clothes to dry, all sorts of those types of activities. Displaced, as I mentioned, by the increased use of appliances. Suburbanization has meant that physical activity has been engineered out of the days of many people because it's no longer possible for children to walk to school. Many of the suburbs lack sidewalks, and even if they have sidewalks, they don't connect those suburbs to places where people want to go. And as a result, people are increasingly reliant on cars, and we know the more time that someone spends in a car, the more likely they are to have obesity. And finally, we're in a post-industrial society, and there's been a shift from manufacturing to services, which has meant a decrease in the amount of energy that people are spending on physical activity. As Linda mentioned, there are other behavioral factors associated with childhood obesity. important to this conference is that pre-pregnant weight, excessive weight gain during pregnancy, and paradoxically tobacco use during pregnancy and gestational diabetes all lead to early childhood obesity. So this prenatal exposure is an important contributor and one which has not been well studied. We also know that, as Linda pointed out, that reduced sleep is associated with an increased prevalence of obesity, and there have been really sound meta-analyses of both tobacco use and sleep in showing their linkage with early childhood obesity. Television time, a form of sedentary behavior, is associated with obesity, but that effect seems to be moderated or modulated through its impact on food consumption delivered through child advertising directed at children and the consumption of foods advertised on television. And finally, early exposure to a variety of adverse experiences, including abuse, both sexual, verbal, violent abuse, family incarceration, divorce, poverty, drug use, alcohol use, all are associated with an increased prevalence of severe obesity in adulthood. And this early exposure is clearly modulated by brain development. And there are good data that suggest that if we're going to be successful, not only at reducing severe childhood obesity or adult obesity, but also many of the adverse consequences of these exposures, like a history of unprotected sex and incarceration and drug use in adolescents who have been exposed to adverse childhood experiences, we're not going to make a lot of progress in reducing particularly the severe forms of obesity. Now, what's encouraging is, and in contrast to what Linda mentioned, we are now seeing progress in the control of childhood obesity, and the next slide shows the most recent trends in 2 to 19-year-olds in the most recent NHANES surveys. And I mentioned earlier, these NHANES surveys are now done on every 2 years, or I should say the data are collected over a 2-year period. And in both boys and girls, we're seeing a plateau in the prevalence of childhood obesity, no significant increase. And as the next slide shows, we're seeing the same thing in adults, no significant changes over the last decade. And what's particularly encouraging, as the next slide shows, is that we're seeing decreases in the prevalence of obesity in 2 to 5-year-old U.S. children. This slide shows 2 different data sets. The NHANES data are on the bottom, and the pediatric nutrition surveillance system is on the top. These surveys differ substantially in how the data are collected. The NHANES are measured data, but a relatively small sample of 2 to 5-year-olds, and you can see the impact of that, of how small that sample is by the wild swings that you see in prevalence. Nonetheless, I think the changes in NHANES are consistent with a decrease in the prevalence of obesity among 2 to 5-year-olds. The upper graph is the pediatric nutrition surveillance system, which was a survey that my division at CDC conducted on an annual basis. This consists of largely 2 to 4-year-old children, most of whom were enrolled in WIC, so it's a vulnerable population. And you can see, although obesity steadily increased up until about 2005, it seemed to peak and then decline by about 0.8%. In contrast to the NHANES, this is a very large sample of hundreds of thousands of children, and these results are limited to 18 states in which a significant decrease of obesity occurred. And in the next slide, as we look around the country, we're also seeing decreases in the prevalence of childhood obesity in 6 states and 16 communities, and there are now several more that have reported these decreases. In contrast to the data that I showed you in the last slide, these data and these samples are much more variable. The ages are different. There's still work that needs to be done to validate these samples to assure that the samples themselves are comparable. But I think we can say in some of the states and communities which have been examined pretty intensively that there are significant decreases in the prevalence of childhood obesity. And it's worth asking why. Well, that work is just underway, at least in a qualitative sense. We and other groups are beginning to look at some of these states and communities that have reported these decreases. But from the national level, as the next slide shows, there have been substantial changes in food consumption. Sugar drinks, primarily sodas, have declined substantially in children and adults. And notice this is about 70 calories in 2 to 19-year-olds and 45 in adults. And there have been significant decreases in the prevalence of fast food consumption, including pizza consumption, and an agreement between companies that supply 25% of the calories in the United States, the Healthy Weight Commitment Foundation, which pledged in 2010 to reduce calories in the U.S. food supply by 1.5 trillion calories, achieved a reduction of 6.4 trillion calories last year, which amounts to 78 calories per day. Now, when you think about the changes, the more recent changes that we're seeing in prevalence, these changes could obviously account for a flattening of the curve. And although we don't have great data on the 2 to 5-year-olds, that small caloric decrement that I showed you earlier could explain why we're seeing decreases in our youngest populations. Nonetheless, that's no cause for complacency because we still have a prevalence of about 20% of obesity in 6 to 11-year-olds and about the same, maybe a little more, in 12 to 19-year-olds, and about 34% of the adult population is obese. And as was mentioned earlier, this is a significant drain on the medical resources in this country and accounts for a significant burden of disease. Type 2 diabetes, cancer, cardiovascular disease are all increased in obesity. So the data that I've shown you on the macro environment don't undercut other hypotheses about contributing factors. But the final common pathway is energy balance, and the changes in the macro environment make it much easier to consume food and much easier to be inactive. And I completely agree that it's critical to understand other factors, both in terms of their impact on prevention and even perhaps on treatment. So thank you again for inviting me. I'll look forward to the discussion.